And it's a delight to be here in Denver, even though my luggage decided to stay in New York. So it's a privilege to be here with so many friends and colleagues. We look forward to seeing you all here for TCT in a few months, also in Denver. So my task was to talk about reentry, but you just heard a tour de force about reentry from Nick, which is really it's a tandem conversation. Crossing and reentry really go together, as he elegantly pointed out. I just wanted to make then a few points about CTO crossing and reentry. First, the plaque morphology of the peripheral CTO particularly is really plagued by dense calcification. And so the path of least resistance for crossing the CTO really is the pathway that avoids calcification. So I think this conversation about luminal versus intraluminal is a little bit contrived, in the sense that you're really going to try to cross however you can cross and take the path of least resistance. Subintimal dissection and reentry has been talked about a lot already. There's no clear difference in midterm outcomes, at least in my review of the data. And the wire loop strategy is potentially unpredictable. And so there have been a host of CTO devices and reentry devices invented that Nick just referred to. Meta-analyses are of relatively little value in terms of looking at the subintimal approach with respect to technical success, patency, and limb salvage. And you've already seen these data, especially the data from Dr. Soga in Japan, where there seems to be little difference in patency in the near term, whether you take an intimal or subintimal approach. So you've already heard about the panoply of crossing devices and reentry devices. And let me, instead of reiterating what Nick already talked about, let me make a few points. You've seen a sampling of the crossing devices, and I'll focus on the reentry devices as I was tasked. When I look at these devices, and Nick went over these in some detail, I really think about them in terms of what is their applicability with respect to how big the subintimal plane is. When you use an 035 wire strategy, you tend to make a larger subintimal dissection channel. And I find that the big subintimal space devices are these three: Off-Road, Outback, and Pioneer. If you're far away from the lumen, having a longer needle or a balloon that can reduce that space are going to be far more effective at re-entering the true lumen than having a small, flat, stingray-like balloon that needs to be really hugging the intimal surface. So generally, I think the device that's selected for re-entry is predicated on your wire crossing strategy. If you use a 014 or 018 wire crossing strategy, the subintimal plane tends to be smaller, and you may be successful with N-tier, even if you didn't use the Viance catheter, which is the paired crossing device. On the other hand, if you use an 035 wire strategy and have a deep subintimal plane, you're going to probably need a catheter with more reach to get to the true lumen. And you've heard that re-entry success can be up to 90 to 95% with current devices, but the biggest predictor of failure is calcification. And I think you'll hear a lot about ways to avoid this. And certainly you want to try to avoid more subintimal dissection and preservation of collaterals in any case when you use re-entry. So let's just show some examples. This is what I would call the old-fashioned way. It's an 88-year-old patient with critical limb ischemia, and she has heavy calcification of her arteries and has clean inflow, but you'll see in a moment she has heavily calcified occlusion of the SFA. So this is what I would call the best re-entry device, which is using a wire catheter strategy with facilitated dissection. So here, this is what a shallow loop wire technique looks like. I tend to use glide wire and Navicross as my support catheter wire combination. And then when you get stuck, there's a variety of things that you can do. In this case, we use the laser to get past an area of heavy calcification, and then continue our loop wire approach. And then using a glide wire M, which is like a heat-seeking missile for the true lumen, I find. We were able to, just with a wire strategy, get back into the true lumen and confirm our luminal plane and finish the case. I'll proceed. So now what about the Outback? As a typical CLI type of patient, dialysis-dependent renal failure, aortic stenosis, 90 years of age with critical limb ischemia. heavy calcification, really short segment occlusions, but with popcorn calcium. And sometimes these are the most vexing because you think you should be able to cross them easily, but they can be difficult to cross true lumen. What happened was that we basically got deeply subintimal trying with a series of different wires, and we needed to get into the true lumen. And after about 10 minutes of trying, we decided we need to re-enter. And I show this picture not so much because we are able to successfully re-enter, but basically this is what you're often plagued with. You have heavy, heavy calcification. And of course, I selected the image where we actually got in, but I didn't show you the 10 other attempts of trying to poke and puncture into the true lumen. And so what I really think is important is to be able to get good visualization with a high magnification view and try to find, if you will, the softest spot possible to try to re-enter the true lumen with any of these needle-based re-entry devices. And I think for this reason, sometimes if it's not angiographically visible, using the Pioneer device will be helpful. The other point I'd want to make is that these sites of re-entry, as you can see, we're extraluminal in this area around this heavy dense calcium from 15 to 21 centimeters. You can see the balloon wrapping around. So I generally will aggressively pre-dilate these areas because I find that these are often an area for TLR in the long term. And so usually these need to be stented, and there's your final result. But the re-entry site, especially in dense calcium, can be a nidus for failure in the future. And then finally, here's an example, another heavily calcified claudicant with a long segment CTO. This is sort of a case where this is the Wildcat device where we were able to cruise down through calcium until about the last 10 centimeters, and then we eventually had to succumb to using Pioneer Plus to re-enter. And you can see the difference here is that you have a 14 wire through the true lumen of the Pioneer device, as well as one coming through separately through the needle. And so consequently, this device is a little bit larger in caliber and frequently needs pre-dilatation for delivery to the target re-entry site. And there's your final result. So you've heard already about some of these other techniques, and you'll hear more about them as Art and others speak in the session. Using facilitated re-entry, I would say that the one re-entry device based technique is this so-called re-entry assisted fenestration, where you have a retrograde balloon and an antegrade needle-based re-entry device that can allow you to puncture from one subintimal space into another and then facilitate wire access to the spaces and reconnect the two subintimal spaces. So if I were to identify any simple tips and tricks, they would be: don't make the subintimal space larger than necessary. And Manas can talk about the straw technique and other things that are used in coronary. I find that to be less helpful, where you would aspirate blood from the subintimal space to really compress that space. I think these 035 wires are very aggressive and create large subintimal dissection planes. I don't think that switching reentry devices makes a lot of sense unless you're changing from one mechanism to another. In other words, if you use an anterior catheter and you have a shallow subintimal plane and you can't get in, it makes sense to go to a reentry device that's got a bigger reach. But I don't think that there's an appreciable difference, in my opinion, between the other three devices with respect to their reach. If you can't get there into the true lumen with one device, it's not likely you'll get there with another, but I'd be willing to hear what the panel say. And I would pre-drill aggressively at the re-entry site in order to prevent TLR. I do hope that we'll get some time to talk about developing this hybrid algorithm. I know Manas is going to talk about this, but I think we are ripe in the field to now, with the tools we have, both with wires, catheters, re-entry devices, and CTO devices, to start programmatically escalating our wire strategies and then re-entry and retrograde strategies. So I hope we get a chance to discuss this. And I also hope we get to discuss using axial imaging as a potential way to plan our procedures. We're working on this in partnership with Siemens at Columbia to see if CT angiography can help us plan more effectively which approach we're going to take a priori for CTO crossing. And we're hopeful that using axial imaging like this will allow us, as it may in the coronary, to do more aggressive preparation for CTO crossing in complex cases. So again, in conclusion, CTOs are a challenging and difficult arena to treat in the SFA. Re-entry is still frequently required. I'm impressed that John gets across with a wire catheter 85% of the time. I think the gray hairs that I trained with said the same thing to me, but I find that it's often faster to pull a reentry device, and we'll hear about the economics in the coming lectures. I think this reentry success is dictated largely by the presence or absence of calcification and experience with individual devices, and I think being facile with different devices is really important for any operator who wants to take it to the next level for peripheral intervention. Thanks very much.